Hey all, Eric Christensen from the Real Life Pharmacology podcast. I am a big podcast listener. I like learning different things and just stumbled across a podcast that fits right in my wheelhouse, and I'm guessing it'll fit in yours as well. You got to check out the Mechanism of Action podcast. It reviews a lot of history about where medications came from and were derived. It's really going to help your understanding of medications and also be a little bit entertaining as well. So go check that out. Highly recommend it. Mechanism of Action podcast. Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you for listening today. I am going to cover gastrointestinal antispasmodic medications today. There are two of them specifically that I want to cover. Dicyclomine, brand name is Bentil, and hyoscyamine, brand name is Levsin. So when I'm talking about these two medications, I alluded to the fact that they're antispasmodics, so they're going to stop or help relieve gastrointestinal spasms that can be painful and irritating. These meds have been around for decades. They're considered older agents. They do play a potential role in helping with that pain associated with abdominal cramping. So from a broad perspective, these medications reduce the involuntary contractions of smooth muscle found throughout the gut or the GI tract. So again, reducing abdominal cramping, reducing intestinal spasms. They can be useful in patients with gastrointestinal hypermotility disorder. So that's basically disorders where the gut is too active and the propulsion is too great or too frequent. And then probably the most common situation I've seen this in is patients diagnosed with IBS or irritable bowel syndrome. And patients can have significant pain associated with that syndrome. And rarely you may see these antispasmodics used for that. I will say that with the caveat of ACG, so that's the American College of Gastroenterology, their guidelines actually recommend against the use of antispasmodics, such as dicyclomine or hyoscyamine, for the treatment of global symptoms of IBS. Okay. With that said, in practice, some experts I have seen use these medications usually on an as-needed basis for the relief of that abdominal pain associated with IBS and cramping. Usually, these medications are used on a short-term basis. They're used on a PRN basis. I see quite a bit as well. So that duration, generally we want to avoid longer than 2 weeks if we're using it on a little bit more of a scheduled basis. These medications are highly anticholinergic, and I'll go into that coming up here as well. So mechanistically, understanding that these medications are anticholinergic, they competitively block muscarinic acetylcholine receptors located in the gastrointestinal smooth muscle. And when we block those receptors, that causes relaxation of intestinal smooth muscle. It reduces GI motility, so it slows the gut down. Obviously, it reduces intestinal spasms, and that can help relieve that abdominal pain. Now, a good way I try to remember this kind of interplay with acetylcholine, recall that acetylcholine stimulates smooth muscle contraction throughout the GI tract. So a medication like donepezil, that is an acetylcholinesterase inhibitor, that actually increases the amount of acetylcholine. Aricept, or generic name donepezil, can cause significant GI upset, can cause diarrhea and things of that nature. That's because we're increasing acetylcholine. Now, when we use an anticholinergic medication, we are blocking the action of acetylcholine, and that's what a medication like dicyclomine does. And it can help relieve some of the painful cramping associated with various GI conditions. This slowing down of the gut also explains why constipation is such a common complaint when we use anticholinergic medications. So, going into the specifics a little bit more, dicyclomine, again, brand name Bento. This is the most common one I see used in practice, the most common GI antispasmodic. Usual dosing, 20 milligrams by mouth, can be anywhere up to 1 to 4 times daily. If patients have symptoms that seem to be worse at specific times of the day, we may target that, dose once or twice a day. If it tends to be all throughout, we're gonna dose that a little bit more frequently, potentially. It can go up to 40 milligrams 4 times a day. If patients are showing no improvement, obviously this is a medication that we want to avoid and discontinue. We can have all sorts of anticholinergic adverse effects, and I'll get into those coming up here. Usually this medication is given just before meals, ideally. That typically makes sense with what most patients report, and that is usually pain after eating, because when we take in food, that stimulates our brain to basically produce movements in the gut to chew up and absorb that food. And when patients have that overactive gut, potentially associated with IBS, once those contractions get going, that's the painful time frame for many patients. So in most patients, I would say 30 minutes before the meals or right around the meal, that's when the medication is probably ideally given to reduce or minimize those cramps. All right, let's talk adverse effects, and I definitely want to bring in the prescribing cascade here. These medications are anticholinergic, okay? So adverse effects, dry mouth, and one of the most common things that might tip you off for this is a patient who takes a saliva substitute or who needs a saliva substitute, okay? So that's a good little tip there. Constipation. So if you see somebody taking dicyclomine and now they need to add laxatives to their medication regimen, well, the dicyclomine is probably causing constipation, which is leading to the need for laxatives. Blurred vision, dry eyes, artificial tears is kind of another tip-off to an adverse effect of dry eyes from an anticholinergic medication. These can sometimes be a little bit sedating. They can cause some drowsiness. On rare occasion, I see some stimulants and those type of medications used to help keep patients alert and awake. Urinary retention, another common one, really big problem in BPH, patients who are already at risk for urinary retention symptoms. I've seen medications like tamsulosin added, like finasteride added to a patient's medication regimen after an anticholinergic medication like dicyclomine has been utilized. Okay, so really important to pay attention to that. Anticholinergics can also contribute to some dizziness and fall risk, so that's really important to pay attention to as well. They can also contribute to tachycardia as well as reduced sweating. Now, those typically aren't as common, particularly in lower to moderate dosages, but as we escalate dosages and potentially get into the situation of an overdose type setting or too many anticholinergic medications on board, this may be more problematic. Elderly patients are specifically more at risk as well for a lot of these adverse effects. They don't tolerate these medications quite as well or as easily as somebody who's younger. A few things specifically I wanted to mention about hyoscyamine. Again, that's brand name Levsin. Again, I don't see this medication used as commonly as dicyclomine, but I did want to mention a little bit. So we've got some variations in dosage forms, so that can be useful, and maybe that's why you see hyoscyamine versus dicyclomine. We've got immediate release tablets, we've got some sublingual tablets, we do have an oral solution, we do have some extended release versions as well of this medication. So again, this may be desired in that situation, particularly if you've got a patient that's maybe having some trouble with stomach upset, maybe some nausea, some vomiting as well. The sublingual formulation may be a little bit more useful there, and maybe a little bit quicker onset as well with the sublingual formulation. Typical dosing of this medication, usually starting dose is in the neighborhood of 0.125 milligrams every 4 to 6 hours as needed. Again, that dosing varies a little bit based upon the formulation you're using, and we can escalate that dose, of course, as well. Administration, again, typically you're going to time it a little bit like dicyclomine, particularly with the immediate release. When we're going to give that around meals, maybe just before when that gut is most active. Obviously, the extended release product is a little less time sensitive. It kind of gives more of a sustained release over time there. All right, let's take a quick break from our sponsor, and then we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study materials like BCPS, ambulatory care, geriatrics, NAPLEX, or others, go check out meded101.com/store. We've helped thousands of pharmacists prepare for and pass their board exams, and we can absolutely help you as well. All those links you can find at meded101.com/store. In addition, if you're looking for Amazon books, crossword puzzle books, pharmacology education, nursing review course, we've got a bunch more resources that we've released in the last couple of years that can absolutely be helpful to various folks. So again, if you enjoy this podcast, please support the podcast. Go to meded101.com/store. Find some alternative resources that might help you study and prepare for pharmacology exams and pharmacology courses. Again, all those links, meded101.com/store. And thanks for your support. All right, let's talk drug interactions. There aren't a lot of specific drug interactions through CYP enzymes, so that's nice with these medications. One of the most important things I'm looking out for is the additive effects from anticholinergics. Often in practice, we call this anticholinergic burden, where a patient is taking numerous medications that have anticholinergic effects. So let's go through some of these. Diphenhydramine, brand name Benadryl. Amitriptyline is a tricyclic antidepressant that I do see used in practice quite a bit. There's also nortriptyline, desipramine, lots of medications from the tricyclic antidepressant class, and they all tend to have some anticholinergic activity that could add on top of dicyclomine, cause confusion, constipation, dry eyes, dry mouth, urinary retention, maybe even some dizziness and fall-related risks as well. So big problems with some of those anticholinergics. Another anticholinergic, this was the urinary anticholinergic, oxybutynin. That can definitely have some central nervous system adverse effects as well, contribute to that confusion, delirium, as well as all the other anticholinergic adverse effects. Benztropine, that's brand name Cogentin. Occasionally, patients with Parkinson's disease may be on this. Occasionally, you may see this medication utilized in patients taking antipsychotics that cause extrapyramidal symptoms. So again, benztropine is a medication that can add to the anticholinergic burden of the GI antispasmodics. Other medications you may see that have some anticholinergic action, hydroxyzine, sometimes used for anxiety. Occasionally I see that used for certain types of pain as well. Meclizine, promethazine, cyclobenzaprine, that's a muscle antispasmodic type of medication. Even an SSRI like paroxetine does have some anticholinergic action. And again, they can all have additive effects. So taking these medications sometimes alone may be tolerated pretty well, but as we add more and more medications with anticholinergic action, we can have this cumulative additive effect that can become clinically significant and cause some of those adverse effects. A few certain patient populations to pay attention to. Anyone with narrow angle glaucoma, we're generally going to want to avoid anticholinergics like dicyclomine. Patients with active urinary retention, that can obviously be problematic. If we've got gastrointestinal obstruction, stopping or slowing the GI tract can be additionally problematic. All right, well, I think that's going to wrap up the podcast for today. Thanks so much for listening. Please support the sponsor, meded101.com/store. Your purchases there go directly to help support this podcast, so I greatly appreciate that. Any questions, comments, feel free to reach out to me. Eric Christensen, PharmD, BCPS, BCGP. You can find me on LinkedIn, or you can email me at mededucation101@gmail.com. As always, please share us with friends, colleagues, students, classmates, anybody who could benefit from some pharmacology education. I greatly appreciate that. And leave us a rating and review on iTunes or whatever platform you're listening on. That is greatly appreciated as well. Don't be afraid to go back to the archives at reallifepharmacology.com. We have, I believe, over 400 episodes now. You can hit the podcast button and you can look at that search bar and you can specifically search a medication that you're interested in learning more about. So that's definitely a no-brainer if you're preparing for exams or just trying to become a better healthcare professional that has a little bit better background in pharmacology. So feel free to do that at reallifepharmacology.com. With that, I'm going to sign off for today. Thank you so much. Take care. Have a great rest of your day.